So this is our bone health meetup, and I'm going to give you a presentation about bone health in general and osteoporosis and the hows, whys, and what's to do. And then a little bit on nutrition, though. What I would draw you back to or guide you back to is also the session that I did that would have been uploaded a few months ago, so it'll be closer to the beginning of the meetups, the early ones of the meetups, the one about joint health. So they're very overlappy, and there will be some repetition in the nutrition section from tonight from that session. But I also won't go into as much detail with the nutrition this evening, so that if you want to find more information about the nutrition or go into more depth, then go back to that joint health meetup. I think it's probably the second or third meetup that we had. So I will share my screen that way that I'm so impressed with myself being able to do. I feel very grown up. So you can see that? Yeah, great. Thank you. So I always try and give a nice little kind of subtitle to the presentations, and sometimes it just kind of trips off my tongue as I'm typing. And I just wrote nature and needs, and I thought I have no idea what that means. But as I came back to think, well, what will I change that to? I couldn't think of anything else. And what it means to me is the nature of bones, what bones are, but also the nature of osteoporosis and the needs we have either to protect against getting it or what we do when we have it really is the thing, because it is not something that is reversible, unfortunately. So this is a bone, and actually it's a femur, which may be helpful to you to notice. I only just noticed that now. You can tell by this situation here, or it could be is it the humerus? I never remember. Yeah, the upper arm bone, because that neck is quite short, but it's either a femur or a humerus. I'm guessing a femur. So we've got the long, here would be the knee down here, and you've got the long shaft going up. And then we get to the greater trochanter, which is the sticky out bit on the left of this image, on the side where it says veins. And then the bigger sticky out bit on the right, just above where it says arteries, that is the ball of the ball and socket joint. So our shoulders are a ball and socket joint, but so also our hips. And here the thin bit is the neck of the femur. And actually this, when you have a hip fracture, this is me going way ahead, but there is no other image of a femur in the presentation. A hip fracture is not actually a fracture of your hip joint. It's kind of, it would be hard to understand how a hip itself would fracture because it's a ball and socket joint. So what are we talking about? What's actually fracturing in that case? Really, if the socket of the hip fractured, that would be a fracture of your pelvis, because it is part and parcel of your pelvis. So actually what is referred to as a hip fracture is this neck of the femur here, this thinnest bit along where the dot of the thing saying arteries is. So that's where a hip fracture happens, and it's usually in the middle, the thinner part of it, but also sometimes a little closer to, can you see my cursor? My little arrow? Yeah, great. So, oh, now it's disappeared, of course, just give me the lie. So it's also sometimes in this junction here where the neck turns into the top of the femur towards the greater trochanter. So it's actually a femoral fracture. The neck of the femur fractures in a hip fracture. And a hip replacement is where they put a metal thing that is basically a ball and a line and a piece down here that they attach to the bone. So a hip replacement is usually this part, and a bit of a shaft. So that is just a bit of a side note. So what I want to just to show you here is just some of the structure of the bone. So here where it says spongy bone, that is known as trabecular. Oh my God, yes. And the yeah, trabecular or cancellous. I knew there was another word beginning with C. So there's two names for this spongy bone, trabecular or cancellous. And then the outside bit is your cortical bone. Now, all of these parts of the bone can get osteoporosis, but it is usually earlier seen in the trabecular. And areas of the body that have more cortical than trabecular may experience osteoporosis later and are usually just a bit more dense. This may be one reason why, if you have osteoporosis in your spine, the sticky out bits at the back of the vertebrae are less prone to fracture than the bodies, the rounded bodies of the vertebrae that we would see at the front of the spine with the discs between, that kind of image we would commonly have. The fronts of the vertebrae are more trabecular and the spinous processes are more cortical, so they're harder. But that's not to say that they can't fracture and can't develop osteoporosis. The other important thing here for me in this image is the periosteum. So it's pointing to something that's hard to see. It's a skin around the bone. And that skin is the tissue through which blood and nerve signals, nerve signals and blood supply travels. But it's also a tissue, a skin, which has these things in it called osteoprogenitors. It doesn't matter what the names are, but it's got cells waiting to be stimulated to become something called osteoblasts, which are other cells which are then waiting to become osteoclasts, which are bone, osteocytes, which are bone tissue. Osteoclasts are the cleaning up cells who break down old bone tissue. Osteoblasts are waiting to become osteocytes. So we've got clearing cells, waiting cells, and bone cells as listed here. What I think people are very unaware of is that there's a high proportion of water in bones, which is why hydration is important for bones as well as tissues where you would be fairly, fairly obvious that hydration is important. I mention collagen here because when we lose bone mineral density, it's the substance between the scaffolding that disappears with low bone mineral density. So basically we have a web. I don't know, I think you can see my image at the side of this, but not on the recording actually. So I'm just interlacing my fingers. You have a web of collagen, and in between the web, in the spaces, is where the minerals like calcium, etc., deposit themselves. So it's when the minerals are lacking in those spaces that we have low bone mineral density, and so it looks more porous. The gaps are empty. We can, of course, also see decrease in collagen, decrease in calcium structure, structure, scaffolding is what I was trying to say. And there is some research into the benefits of taking collagen supplements for even bone density, but also there is a thing called bone quality. And bone quality is different. It's to do with resilience, no matter what the bone density. But pretty much nobody gets measured for bone quality. Unfortunately, it's not a test that's done on a regular basis at all. It's usually more for research purposes, but it can determine to a degree, if you were to know your bone quality, you may get a lower fracture risk with your osteoporosis. And so collagen would be one of the components of bone quality. So it's not just about the minerals in between the scaffolding, but obviously that's very important as well. You're welcome to stop me with any questions if you want, because there's going to, this is a lot of new learning, but it's just giving you a background. You don't necessarily need to know all this. So our childhood and teenage years are really important for our bones, but none of us really, though we were told maybe once or twice, really did much about it. I really don't know any child or teenager who would be concerned. and would have decided to go muscle building and making sure that we're having lots of calcium, etc. And the best we got, I suppose, in our generation was make sure to drink your milk. And we certainly should have been supplementing with vitamin D, but we wouldn't have known that. So in those years, your genetics and your the available food that you had, any issues like maybe if you went on drastic diets or had any eating disorders, or if you had celiac disease, or if you were a big smoker, or if you did a lot of binge drinking in your teens or 20s, that's going to be more influential of your osteoporosis scores when you're 60 than really menopause in a way. So if you're already starting at 20 or 30, late 20s, early 30s, well, late 20s really, which is when we reach peak bone mass. If you're already at a deficit then because of things that got in the way of reaching peak bone mass in your youth, then you don't have as much in the bank, as it were. So when a DEXA scan is done, when mineral density is determined, it is relating to your minus score that you get when you have osteoporosis or osteopenia. Your minus score is relative to a white woman, a Caucasian woman, about age 30. So that is the reason it's a white woman is that Caucasian women are the most prone to osteoporosis. So they measure bone density against a Caucasian woman at peak bone mass, which is late 20s, early 30s. So when we get into, well, once we go past 30, we're already seeing the balance of building to breakdown change. And this is what it's all about. As we're going up to 30, there is more building than breakdown. And from 30 on, that balance shifts. Maybe it's level for a while, and then it starts to be more breakdown than building. So in perimenopause, there is a debate about whether there is accelerated bone loss then. There is some relationship between follicle stimulating hormone being investigated as a contributor to osteoporosis, that it's not all about low estrogen. This is something very new to me. And that would mean that there is a bit more bone loss in perimenopause, whereas previously we've thought that it's just this accelerated time after menopause, which is to do with estrogen. But actually, FSH can remain high then anyway. So it may already be starting to decrease in perimenopause, but there is a sharp fall just after menopause, but that levels out again so that it doesn't continue a sharp fall, but it will continue to decline until the day you fall asleep at 105 and don't wake up again, if you're lucky enough to go that way. Yeah. By the way, the skier is obviously, this is the sharp downhill that I was trying to indicate rather than the muscly bits that of the other pictures. So as I was saying, it's whether you develop osteoporosis or not is relative to where you got to in your 20s, late 20s mostly. And while that's the stage that will be, if you had a DEXA scan then, they might be able to say to you, oh, you're very likely to develop osteoporosis. And maybe, for instance, if they did do that, if they DEXA scanned women as they entered perimenopause, say late in their late 30s, that would be a really helpful thing, because it might help a woman decide whether to go on HRT or not, because that is the health risk that has the most definitive benefits for HRT is osteoporosis. So if you discovered that a woman in her late 30s was already not at optimal bone density, then that would be a really good reason for her to go on HRT in those very safe years of perimenopause. And as I said, there's the things that are going on in babyhood, childhood, and teen years are very important. So obviously getting enough nutrition as a baby, as a child towards a teenager, again, it's about nutrition. It's also about natural body size. So if you happen to be, so this image of the two women here, if you happen to be in a small body, you're more likely to develop osteoporosis than if you're in a larger body. But then 15 to 20, 25 is the kind of lifestyle situation that a person could get involved in, where they could decide they're going to do some strength training. But if someone's, for instance, doing a lot of athletics, very endurance athletics, they're more likely to develop osteoporosis. Someone who is not menstruating, if there's amenorrhea for any reason, maybe from overtraining. Someone who is not eating properly, maybe an eating disorder or celiac disease would be causing potentially malnourishment. But once celiac disease is under control and the person is eating enough, then it's no longer a risk factor. So it's all relative to the peak bone mass age, but it's also, there is a genetic component as well. That may be to do with body size. It's also to do with race. So that's the middle pictures there. Is if you're female, you're more likely. If you're in a small body, you're more likely. And if you're Caucasian or Asian, you're more likely to develop osteoporosis, and if there's a family history. So as you see here in the image on the right, the changeable facts are being sedentary. So that's that lady in the fantastic chair. It's very important to sit in a fantastic chair every now and then and do absolutely nothing. Stress, there's the woman pulling her hair with her very rouged cheeks there. Smoking and alcohol, particularly alcohol in our late teens and 20s. Celiac disease is the picture of that little gut there. Eating too little is the why I have the picture of the weighing scales. And then don't be an astronaut. So that's indicating that when we don't have weight on our bones, we are more likely to develop osteoporosis. Astronauts absolutely do develop osteoporosis, and that's why something like that's one of the reasons there is that there's no weight on their bones, and that's one of the reasons why people in larger bodies are less likely to suffer. Sometimes it's because they have bigger bones, and it's just there's more to be going on with, but it's also to do with having less weight on your bones. So a lot of people are using weighted vests now because everybody's so obsessed with not being large, and yet they know they need the weight. And walking with a weighted vest seems to be a thing that people are doing, or running with a weighted vest these days. But if you do have osteoporosis, there's a lot of things you have to be careful about doing, and wearing a weighted vest may not be advised, and you need to talk to your medical practitioner about that. So the ways you know whether or not you have osteoporosis or not, obviously when I say the gold standard is the DEXA scan, that is, the very typical way of looking at bones. There are flaws in the DEXA scan. For instance, if I have a DEXA scan in one facility, I will probably get different readings than a DEXA machine in another facility. There seems to be quite a bit of disparity between DEXA machines. And so that's why if you've had a scan, you'll be told to go back to the same place and hopefully have the scan on the same machine. So some people, there is screening for osteoporosis, I think, over the age of 65 in Ireland. Anyway, I don't know about other countries of people who are in the membership. I think it's probably similar in the UK. But many people don't know they have osteoporosis, and they discover through these other reasons that are indicated here. So one is a loss of height. The other is a rounded upper back, which may indicate a vertebral compression fracture. The loss of height will also indicate vertebral compression fractures, where the front of the vertebral body compresses and fractures. And then the picture at the bottom is indicating a low impact fracture. So when you fall from standing and you have a fracture. I was very annoyed that the only image I could find of something that looked like it was indicating a hip fracture and was female also has that classic thing they do in those silhouettes of putting a little bun on the top of the head to indicate old lady, because of course everybody who's over 50 wears a bun on the top of their head. But apart from that, a low impact fracture doesn't only happen. I mean, correct me if I'm wrong, but that image immediately conjures up a lady in her 80s, doesn't it, or 70s at least. And in fact, there was a walking stick in the image that I decided to blank out because I need you to know that these things can happen way before you get into your dotage. In fact, a vertebral compression fracture can happen even if you only have low bone mineral density, not even an osteoporosis score, but an osteopenia score. So it's important to be aware of the difference between osteoporosis and osteopenia, and yet they're not that different. There are still risk factors for fracture with both. So it's a charming subject to be talking about. It's not easy. And it's not easy to treat, which is really tricky. Actually, I'll just let me just go on. Yeah, so just to go back before I get distracted with other pictures, it's not reversible. It is very difficult to medicate. There are a few different medications, and they are all not safe to use for more than a certain number of years because of the effect they have on the bones. And if you take them for too long, they can actually make the bones quite brittle. So it's like, it's often it feels like you're stuck between a rock and a hard place. Hormone replacement therapy or hormone therapy for a young woman would, meaning up to 60, would probably be your best bet for bone density, if there's no other risk factors involved. And even if you're postmenopausal, if you're young enough, you can start hormone replacement therapy, but the risks increase the later you start, particularly the later you start, much more so than if you started early and are continuing. And some people are just contraindicated for HRT. But that if it is safe for an individual to take it, it's probably the safest route. However, when you come off it, you will have a drop of bone density. So if your tendency is towards osteoporosis, you can't reverse it. It just is what your makeup is doing and will continue to do. However, there's confusion where in the UK, I'm pretty certain that HRT is licensed for treatment as an intervention after an osteoporosis diagnosis. But in Ireland, certainly my doctor said that it is not licensed for use as a treatment after a diagnosis of osteoporosis. Dr. Mukherjee, the endocrinologist who mentors me around this medical stuff, has indicated to me that it is an accepted use of HRT is for someone who's young enough and has osteoporosis. So it's certainly worth debating with a GP or a personal care physician if you are facing it, especially if you're young like I am. So in our youth, before we get osteoporosis, so that maybe even in 50s, 60s, it doesn't, who knows when you're going to develop it. Prevention, the images on the left here, are eating enough, really important, so important. You can do all the exercise you like for your bones, but if there's nothing to go to the bones or insufficient to go to the bones, you need extra minerals in your diet, more than your organs and other things need. So the bones store the excess so that when there is not enough in the bloodstream, they release it to make sure that you're ticking over. So calcium, for instance, is incredibly important for heart health. So when your blood calcium is low, that's when it comes out of your bones. So if you're eating enough calcium to look after your heart's needs, then your bones won't necessarily need to release calcium into the bloodstream. And how you eat for your bones is mineral-rich diet, and it's vitamin D and vitamin K too that bring the calcium or help bring the calcium to be stored in the bones. So eating enough and regularly is immensely important. Then all the stuff around the eating, the strength training here, this lady on the top right, and the running down the bottom and jumping. But also you'll notice this walker is going downhill. Downhill walking and hiking is better than flat or uphill for bone density. So we're looking basically at impact percussion. However, it's also good to go uphill for your heart, so you can go up and down the mountain. This image in the middle, the greeny one, is very much mostly about yoga type moves and some Pilates. Some of them would be in Pilates too, that are fine and to avoid. But the ones I put in as fine are because they're adjusted versions of what would not be fine. So a forward fold, forward bend of any sort, or you might call it a hamstring stretch outside of yoga, with a neutral spine like this is fine. But with a rounded spine like this is not fine, because we are flexing the spine, and that's what causes vertebral compression fractures when we have osteoporosis. You can get it without flexing the spine, but usually that's why it happens. Tying her shoelaces there, you'll see she's keeping her spine neutral, and that would require a lot of hip mobility there in that front leg, which is why maintaining mobility when you have osteoporosis is incredibly important. And this obviously is a forward bend as well, but it's also showing the hip hinge, which is something that it's very important to teach people of osteoporosis so that they can get down to pick something up off the floor. Learning how to bend from the hips is very important. I've put this little twist in here because a lot of people think twists are not safe, but if the spine is neutral and you're not pulling yourself hard, a twist is fine, whereas this twist would not be good. She's pulling herself very hard. The only reason she's staying there is because of her hands. And for most mere mortals, there would probably be some flexion in the spine if you're able to hold your hands behind your back like that at all. So yes and no would be my opinion. I've put this here because back bending is absolutely fine. And in fact, working on extension of the spine is really important because that's going to help your posture and back strength, but also because it's part of an exercise called cat-cow, where this one down here is the other part of it. So this is cow with the chest coming forward, and this is cat, the rounded one. This is not a good idea. So you'll see that all of these are about flexion of the spine, the black ones. And this crunch here, this sit up, is about flexion of the spine and would be even worse because there's a lot of force in it. I would be absolutely not putting my weight on my head with osteoporosis because of the risk to the neck there. But you don't see that on osteoporosis society websites as a contraindicated posture because they just don't think about people standing on their heads. Most of the exercises they show that you shouldn't do are from Pilates, so I wouldn't be doing a headstand. And then obviously falling is a bad idea because that's, risking fracture from a fall. So when you have osteoporosis, you need to protect your bones from fracture, and that's your priority. You're not going to reverse it, though you can improve your scores. You're not going to magically get rid of osteoporosis. A doctor may tell you not to lift weights, not to jump, not to run if you have frailty in the bones, even not to walk sometimes. But it seems to me that that would be a recipe for disaster. And many people who work in the strength training industry have been studies done on heavy lifting, very highly supervised, and not for too many repetitions. So I'm not going to tell you that these are safe because if you have frail bones, because that is not currently the received wisdom. But I would talk to a personal trainer and to someone who knows more about osteoporosis, a medical person who knows more about osteoporosis than maybe your general practitioner, and consider your options. Because, for instance, if you do have good muscular strength, that will be much safer than if you have osteoporosis and low muscle mass. So you've got protecting structure when you have good muscle mass. So working on muscle mass is incredibly important. These things underneath the red line would be much more doable. Obviously, again, it's eating, all the stuff you need to eat. Then we have, a light resistance training, the kind of stuff we do with the resistance bands. Balance challenges, very important. And I've just put this girl here because she's got a smaller weight. And that's another little band practice down here. And particularly I wanted to put that in because working on the strength of the back body is really important, which is this image up here as well. So working on back strength, so listen up good for this one. Working on back strength would probably be the single most important thing you could do if you have osteoporosis to protect you from fracture, from spinal fracture. And spinal fracture is going to potentially have more impact on your day-to-day living than other fractures. However, a hip fracture is associated with a greater risk of mortality, mostly in people over 65, mostly in more in men than women over 65, and much more in much later life. So don't be freaking out if you get a hip fracture. There is a lot of kind of, oh my God, you're going to die if you get a hip fracture, but really it's not to be feared that much. And if you are somebody who can get up out of the bed and get active after a hip fracture or hip replacement, then you've got a much better option, much better odds. But working on back strength is going to improve your posture, but it also reduces the risk of vertebral compression fractures, having a strong back. So working on posture, gentle work on strength, take advice on bigger strength work. 50 jumps or heel taps a day is a nice little prescription if you decide that jumping or percussion or impact is a good idea for you. Jumping is obviously more impact, hopping is even more, but heel taps where the toes don't lift and you're going tap, tap, tap with the heels is also a possibility. This lovely balancing woman down here, the research we have is 17 minutes of balance training a day. And that means balancing. So the studies that have been done have been something like 200 minutes a week or something of balance training. And it has, just like strength training, it has to be more and more challenging. You have to build the challenge. When something becomes easy, you have to layer it up. When that becomes easy, add another challenge. And that's a big part of what we do in Yoga for Bone Health. So I just wanted to give you this as without pictures so that you have a list, and I would encourage you maybe to take a screenshot of this so that you can just have it easily accessible. I'm just going to look at it while you do that to see if I have covered it all. So yeah, with regard to the balance training, I said 17 minutes per day and increase the challenge, but have a balance aid near you, like a chair or a wall to hold on to. But also standing on a lovely, as I've said this before, I'm sure to you, standing on a lovely flat yoga floor in your bare feet with nobody interrupting you, no traffic going by, and you're not having to go anywhere is very easy circumstance in which to balance. You've got to do things that are more like real life. Distract yourself somehow. Look suddenly behind your shoulder while you're trying to balance, because that's what happens in the world. We're walking, we hear our name called, we look around, we fall, that kind of thing. Regarding strength and impact training, we're looking at trying to do those things 2 to 3, strength training, resistance training, 2 to 3 times per week to build strength. And that's going to depend on you, what level of intensity is going to help you build strength. So 2 to 3 times a week, as I said, supervised if you have got a diagnosis of osteopenia or osteoporosis. And we're looking at, in terms of that strength training, the best results we see for bone density improvement in postmenopausal people with loss of bone, with lower bone scores in doing strength training, is from a trial called the LIFTMOR, LIFTMOR trial. And that was working on quite a low number of repetitions, but very heavy weights at about 85% of what the person could lift once. So that's heavy, would need supervision, and was quite low, as I say, low repetitions, and it was only 4 exercises. But if you're doing lighter resistance, like resistance bands and lighter dumbbells, then more repetitions is a better idea. And there is some research showing that modest intensity is beneficial for bones too, and that's at about 60 to 70%, I think, or 75% of your, maybe not 60, maybe 65 to 75, I must look that up, percent of your capability, your 1 rep max, how much you could lift once. So that's a bit more doable and potentially a bit safer, but it won't have quite the fantastic results of doing that 85%. And as I said, it can be contraindicated, so ask your doctor. And what have I seen there on the food that wasn't in vitamins D and K2, calcium? Yeah, collagen, maybe supplementing with collagen, but at the very least having a lot of protein. And if you're not supplementing with collagen, it can be vitamin C is very important to help us make collagen from protein. Omega-3 is important for bones, as well as every other flippin' body system. Omega-3 is fab, and magnesium too. And the most important piece of it is that stress is a contributor, and also that we build bone while we're asleep, which is not great news if you're struggling with sleep. But our livers actually are partly responsible for our bones. They secrete a hormone at night which helps to stimulate the bones um, to build bone, build new bone. So sleep is important, and rest is important, and stress practices very important. Um, Inflammation to be dealt with, not just because of pain, not just because of digestive issues, but inflammation can also contribute to osteoporosis. But the stress part is to do with the inflammation, but it's also to do with cortisol, which is catabolic. So it's great to finish, I think, the presentation knowing that chilling out is also important for our bones, because it's a lot of an active kind of busy stuff, I think. So any questions on that before I very quickly speed through the nutrition section? Fab. Okay. Where are we? There we are. So as I say, this is dealt with in more detail. There's more talking over it in the joint health recording, but there's a few quick points. Oh, sorry. So I do find visuals are quite helpful, but it's also something that you might want to take a shot of. It's the dairy stuff, it's the bones, fish with bones, it's nuts, it's beans, it's lentils and chickpeas, and leafy greens and tofu. So there is stuff there that's not dairy and not animal. I would point out that it is tricky, the dairy thing, because a lot of us who have osteoporosis also have high cholesterol, high LDL. I mean, the balance is not great, and we need to be being careful of saturated fat. So it's very important not to just dump all your dairy products if you have high cholesterol. So you've got to modify your diet rather than radically change it. So you'd be looking to put some kind of calcium rich food in every meal. So the really important thing about calcium supplementation or food is that you don't want to dose up hugely with it on one meal. It needs a drip drip feed. So maybe have a bit of cheese and some hummus at your lunch rather than just cheese. So that's two sources of calcium, and you don't need to eat as much cheese if you're worried about cholesterol and saturated fat. That kind of thing. You got to get creative. And then if you're having that as your lunchtime, then what did you have for your breakfast? Did you maybe have some nut butter or some almonds and seeds for your breakfast would have calcium, or some yogurt, say. And then in the evening, you might choose to have some a big salad with some tinned salmon and make sure the bones are in it, or some kind of lentil stew, that kind of thing. So trying to get it in every day. But you need, as I said, to get the bones, the calcium, the minerals to the bones, you need vitamin D and you need K2. Vitamin C is important as well, as I said. I think we all know how to get that. Vitamin K2 is in fermented foods, and vitamin D usually, for most of us in the Northern Hemisphere, we have to supplement, and there are very few foods that do contain vitamin D. Liver and egg yolk would be ones that do. So supplementing with calcium is tricky. If you're not, most calcium supplements, or a lot of them, have a few pills, because if you had the entire dose, it would probably be a very big pill. So usually calcium supplements are broken down into a few pills per day. You don't have to take the 3 per day if it's 3. What I would tend to do is take one at a meal that I don't have a calcium rich food in it. But it is possible to overdose on calcium supplements. You have to be incredibly careful with them because of the effects they can have on your heart and your kidneys. And so you do need to bring that to a doctor if you do have atherosclerosis, for example, if you have buildup in the blood vessels, or tendency to kidney stones, etc. So in general, though, I think it's, I can't remember exactly the milligrams, and I shouldn't share that here anyway about calcium. That's your advice to take if you're on, if you have osteoporosis. But in general, I'd be trying to get it more from your food than from a supplement, and think of the supplement as just that, a sort of little addition if there just isn't anything calcium rich in your food. And then when you're taking that, if you have a vitamin D of some sort, like I have this little vitamin D spray and it's 3 sprays a day. So I have a spray with if I'm taking calcium, I'll have a spray then. I don't do the 3 sprays a day. Sometimes because I have a vitamin D in my multi as well. So I will save that spray, that spritz of the vitamin D for when I'm having the supplementary calcium, for example, and I will try to have something fermented in my food. Actually, my vitamin D has K2 in it as well. Protein is important for the collagen, etc. Omega-3, as I said, magnesium, and then all those minerals. Zinc is very important. And then the collagen supplements, as I was saying, there is some good research into them. They're far from conclusive. It's when you see it recommended, they will say studies are good, but more research is needed. But they say that about stuff for yonks until there's hundreds of studies that all come up with the same thing. So you'll hear that again and again. It is important to think of bones not just on their own, because our muscles are incredibly important for our bones, and that's why all the resistance stuff is so important. So looking after our muscle health is incredibly important, and protein is very important too. And all the stuff we've just looked at. Again, I say I'm speeding through this. And obviously, as I said in that last session, the one about joints, we need our joints to be functioning in order to do all the exercise that we need. And also inflammation can increase osteoporosis. So there's that little reminder about the food route to reducing inflammation if we possibly can. And then this whole issue about foods, about enough food is here on this slide again. And I'm not going to go through it. You can take a quick screenshot if you want to. It's fairly obvious what you need to do. To my mind, is just not undereat, really. And a reminder that the food pyramid is backed up by water. That is the bottom of the new food pyramid, is water, 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 or hydration of some sort. Next is lots and lots of vegetables and a bit of fruit, which will give you all your mineral requirements. And then it's your quarter of your plate is protein, quarter of your plate is whole grain carbohydrates, and your good fats for your omega-3. And this is again, apologies for the repetition, but I think this is the best little quote I got from my nutritional therapist mentor, Petra Fulham, which is cast your nutrition net wide when it comes to bones. It's lots and lots of different sources to keep a drip feed of a really wide variety of minerals, including calcium, but a really wide variety of minerals. So I hope that is a nice little speedy, reminder of the nutrition piece. So any questions from those present and correct here? Cool. Okay. So I think I've given you the detail about the kind of regularity of moving, the kinds of movement. Yeah, I think I've covered everything. So what I'll do is I will close this presentation here, and then there will be a recording of what we're about to do, which is just an hour of bone targeted class. So I do hope you'll do that after watching the recording. It's going to be fairly reasonably gentle because it's the evening for us who are here live. So I don't want to do a big bout of exercise when sleep is so important. So a reminder that exercising robustly in the evening is not a great idea for sleep. We're trying to do that in the morning or up towards the early afternoon. However, there will be some fun in the Bony class. So I will stop recording